I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
Call down the first person in line over here. 2 minutes, please. Don't forget to give your name, sir.
Thank you, I'm Donald Johnson. And I'd like to, first of all, this is probably more for some people in the audience rather than the panel, a few textbook facts that nerve cells don't grow after early childhood. We have a set number, and we do increase in brain mass. It's interesting that Piaget, in his theory of cognitive learning, showed logical stages, and then Epstein and others here at the National Institute of Health showed that the brain growth as a function of time up to 21 was in stages that roughly correlated with the cognitive development that Piaget found in France. But the brain mass increase after early childhood is not due to more brain cells, it's due to the axonal and dendrite growth, increased synaptic junction network. So if we're talking about giving electroshock treatment, we're talking about applying somewhere in the vicinity of 400 volts across this network. And as far as counting cells, we're not talking about cells here. The electrical transmitters are the axons and dendrites and across the synaptic junction, rather small circuits. But so the damage would occur there, not in the cell body itself, decreasing necessarily the number of cells, but certainly we'd be talking about where the conductivity goes down the axons. But at the FDA hearings, the testimony on the reclassification of electroconvulsive devices cited the literature as whether signed or false, typically about 150 joules of energy in a treatment. With the new Thymatron electroconvulsive device, if you check out at 400 volts, maximum of 0.9 amps, and 320 some millisecond pulses.
Could you finish up your question, your remarks?
Yeah, I would like somebody to tell me. I'm a teacher as well as a physicist, and I brought a kilogram with me. Teachers like to demonstrate. Now, this is a kilogram. It's 2.2 pounds. Heavier than a hammer I used to hit a nail. But I wonder if possibly like Dr. Stein could tell me how high I would have to drop this kilogram from in order to have it hit the ground with 150 joules of energy.
I don't know if that question is in the purview of the panel, but thank you for your point. I'd like to go on to the next person.
This is only 10 joules of energy. You're talking about dropping it from higher than a 5-story building. That's physics. Supposedly in pre-med backgrounds.
Thank you.
I never doctor. My question is to Dr. Craig. Is there anything in the interesting data presented to us by Dr. Dan which requires reconsideration of your conclusions about the neuropathology of ECT? And if there is, why so? Or if not, why not?
I'll make it as brief as I can. First of all, her study with rats really are absurd. Rats are so resistant to brain damage, and that's very well. They have huge skulls and tiny brains inside them proportionally. Secondly, it's as if she systematically attempted not to find damage. She checks the animals 2 to 12 weeks after their treatments. And Hartelius was very clear in his review of the literature and his own work that the damage is most clearly seen 48 hours after the trauma, because that's when you can see the dead and the dying cells. And after that, there's less and less that's visible because the actual evidence of the damage disappears. The studies on grafts are really not worthwhile. The idea that and she's acknowledging that to some extent studies do show brain damage with epilepsy. The idea that epilepsy itself would cause more damage than epilepsy plus electroshock, that is plus electricity, just makes no sense whatsoever. I mean, we know that some epileptics at least do get brain damage. The idea that when you induce it electrically, it's safer than when it develops spontaneously, it seems to me is so absurd as to not require a response. But I'll give it a brief one. And that is, we know the mechanism of damage from electroshock. It's not obscure. We have angiography on open skull animals. We have angiography on closed skull animals. And we know that when you put the smallest electrostimulation, very small, a few amps, across the whole brain, all of the blood vessels go into spasm. And when the vessels go into spasm, two things happen. And these are, again, cited in the papers I gave to you. Two things happen. The spasm cuts off all the oxygenation to the cells. They blanch. The whole area becomes white and receives no oxygen and no blood cells. And secondly, and we know this going all the way back to the 1940s with Leo Alexander, who was a shock promoter. Secondly, the blood vessel walls break down. So that if you put a dye in a blood vessel in the brain, and you give it just a minimum stimulation, provided it's generalized, the dye will extravasate into the brain. It will break through the blood-brain barrier. So we know the mechanisms of shock damage, and it is really silly to claim that you're more likely to get it in spontaneous epilepsy than with epilepsy that's produced by an insult to the brain.
Thank you.
My name is Joy Rose, and I'm from Media, Pennsylvania. In November of 1982, I took part in a hearing to change the ECA, the electric PCT, from class 3 to class 2. And that's probably the reason I've been invited here today. At that time, I testified about my own experiences with electric shock treatment. And not only did it cause permanent memory loss, but they were given to me without my consent, because I had admitted myself to the hospital under the stipulation that it's not going to allow electric shock treatment. Let's give it 20, 26. I don't remember how many, but it was a great many. And when I left the hospital, I know I not only had the original problems, which I had, which were like economic problems, but now I had to deal with memory loss. I couldn't do simple things. I used to have been an excavator. I could no longer knit. I was trying to make something with my granddaughter. It was embarrassing. I used to be a fine cook. I couldn't cook, all kinds of things. And then I tried to get a job with disaster necessary. I couldn't master a cash register. And I had a bachelor's degree in psychology, and I couldn't do everything. It was really troubling. And I was determined to relearn. With a great deal of effort, I did relearn, everything I had to learn. Last year, on my 57th birthday, I got a Master of Fine Arts in Theater. I've written plays and done so forth. However, you'll say, well, you're fine. No, there is a part in my mind which I cannot get to, no matter how hard I try. And as a writer, that's a terrible thing. And I also want to say that you say, well, it helps you mentally prep. It helps you for a little while to fine, and then you're just back where you were. But I think if someone gave me a 6 drink of bourbon, I would have had the same kind of reaction, and then I would have gone back. My sister-in-law was a nurse who worked with people who were given shock treatment, and she said, this is what happens for 2 hours, maybe a day or two. They seem relaxed. Sure, your brain isn't there. You don't know whether you're just forgetting the problem. So my question is, if ECT is so safe and so effective, why is the APA fighting so vigorously to keep the FDA from testing it for safety? In other words, trying to change it from class 3 to class 2.
Thank you. There is a representative from the FDA who's here today, who might be able to make a comment about that, about the FDA. Would you come to the microphone, please, sir? Your name.
Dr. George Murray, Center for Device and Radiologic Health. For those of you in the audience who are not familiar with what the center does in regulating medical devices, our charge is to test medical devices, new medical devices, prior to them being used in general commercial distribution for their safety inspections. Currently, these devices are in Class 3, which is the highest regulatory class, meaning that there is not sufficient evidence to assure that simple general controls of manufacturing practice, quality assurance testing, and so forth are sufficient to assure the safety and effectiveness. The petition for reclassification is presenting evidence for us to evaluate to see, is there enough knowledge now that for some of the machines or for some applications of these devices, that safety and effectiveness will be assured by simple manufacturing rather than by clinical testing of a new individual machine prior to it being marketed. Right now, the petition has been reviewed for technical data. It is under administrative and legal review prior to its publication. And depending on the outcome of the conference here, if our review is reasonably consistent with the consensus conference, we would hope that if a proposed rule will be published shortly. Once the commissioner signs it, it will go into the Federal Register, and there will be at least a 16-day period for any further new information to be presented after the time that we have evaluated Dr.
Thank you. Gentleman over there, please.
I read the stuff that...
Your name, please, sir.
My name's Hutchinson from Thornton, California. I read Dr. Bregan's book, and I was alarmed about this presumed evidence about brain damage. So I went to a lot of trouble to get the doggone old records and read them. And I find that the good doctor is quite eloquent, but a very poor source. Leo Alexander, whom he alluded to as a shock doctor, was an expert in the effect of electricity and accidental electrocutions on the human nervous system before there was any electroshock treatment. He talked about Hartelius' article not being referred to in others. Neither he nor the other people pay any attention to Dr. Alexander's chapter 11 in his book published in 1953. The chapter is titled The Question of Brain Damage from Electric Treatment. The book title is Treatment of Mental Disorder. When I read Dr. Alexander's recount of the then existing data, Alexander pointed out the importance of the perfusion fixation of the brain in the skull that Dr. Down referred to. And Alexander also referred me to 3 experiments reported in the literature in 1942 or 1944, I believe. No, 42, 45, and 50, where they used, the only 3 reports, where they used in situ perfusion to fix the brain tissue before it could get screwed up. All 3 found no changes. 2 of these 3 were on monkeys, Dr. Bregan, not rats. The 3rd one was on guinea pigs. The people who performed these good studies were outstanding neuropathologists ahead of their time. Bodian was an expert working mostly on poliomyelitis, published fine work at Johns Hopkins University. Dr. Scharrer is the one who, in his 1938 article, referred to by Hartelius, first told about those dark neurons that were the result of trauma to the brain when you handled it when it was freshly dead and not yet fixed. And Dr. Wendell was involved in 2 of those. Now, Wendell headed the laboratories here at the National Institutes of Health that had to do with neurology, neuropathology, and things of that nature in the mid-50s.
Could you finish up your comment, please, sir?
Yeah, I gave you the stuff in the mail beforehand. I hope you pay attention to it.
Michael Allen from Dallas, Fort Worth area. You know, I think we're dealing with 2 things here. We're dealing with an emotional, non-scientific approach by Dr. Bregan, substituted with some pseudoscience and some real science, because I'm not going to take away from what Dr. Bregan has said that has scientific basis. But, you know, he keeps asking the question, why don't the shock doctors say what they do? Well, I'll say what I do. I could have brought 25 or 30 of my patients who told me that they were after the treatment, that brain damage, they're back doing their work. I can't divulge what they do because somebody might know of them. But the point is that if it's true, if the doctor thinks he's doing something that damages someone's brain, then that's unethical. And I just want to say that the time has come to address this pseudoscience. I mean, Melbourne study, the studies that this gentleman just claimed, Dr. Dom's study, clearly showed that ECT provided under conditions of maximal oxygen, etc., does not cause brain damage. Ivor Small and his group in Indiana have done detailed neuropsychological testing which show no acute or chronic brain damage from ECS. Now, there's no question that some people in the past have gotten permanent memory problems with ECT. And those people are probably here. A lot of them are here. And I'm not saying that they're neurotic or there's something wrong with them. I'm saying that they are unfortunate victims of something that happened that probably was not avoidable. But the point is to say throw everything out and leave those hopelessly depressed, delusional patients who can't even talk to Dr. Bragan, who are so busy hallucinating and vegetating and catatonic and dying, just to say that they should be condemned to death because of somebody's idea that he knows better than the entire psychiatric literature over the past 40 years is nonsense. And I think that committee ought to hear that said by someone who doesn't, because I'll stand up and say it.
Yes, sorry, I have to go on order.
My name is Marilyn Rice. I'm the Washington representative of the Committee for Truth in Psychiatry. I would like to introduce this organization at this point between papers on brain damage and those on memory loss. Our organization consists of 68 persons who have experienced permanent memory loss from this treatment. Now, we are not even advocating a ban on ECT. Some of our individual members are, yes, but as an organization, we are simply asking for informed consent, and the only information that counts here is the patient must be told that there will be permanent memory loss. There isn't even a risk. This will happen. It will vary in degree, and some people will notice it more. There will be this permanent memory loss that we have all experienced, and many other people we know. And that means there will be brain damage. And brain damage means destruction of brain tissue. That means the brain will be smaller. This can be confirmed so easily by a CAT scan study on animals. We're trying very hard through the FDA to get an investigation made. I believe that takes care of my 2 minutes. But remember, there are 14 of us here listening to these stories about how we're imagining things.
The final remark before we have the two papers on the psychological effects. Sir?
Thank you. My name is Dick Wheaton. I'm from Indianapolis. I'd like to introduce you to my wife. She's had about over 50 shock treatments, starting in 1962 and ending in about 1975. And since then, she received the Jefferson Award in Indiana about 3 years ago. So I wanted to.
He's proud of me. I hear you saying that patients should know about the controversy and patients should know about the dangers. And I certainly know about the dangers and I certainly know about the controversies. I have had well over 50 ETC treatments. And yet, if I were as ill again as I was then, I would say yes, knowing what you're saying about the dangers and knowing about the controversy. Because I felt that my loss of memory was a very minor inconvenience compared to the terrible misery of my illness. And it is hard to say that I have brain damage because I have accomplished more in the last 10 years than I ever dreamed I would ever accomplish in a lifetime. And it's hard also for me to believe that the suicide rate does not have something seizure because who's to say that if I did not have ECT, I might have committed suicide? Or who's to say that my cousin, who at the same age contracted the same illness and did commit suicide, if she had had ECT, maybe she wouldn't have? That's all I have to say.
Thank you. Again, I'm grateful for the patience of the members of the audience, and we haven't been able to get you so far in discussion. We'll go on now with the next part of the presentation. First, Dr. Harold Sackheim on the short-term neuropsychological.
One shock treatment can equal 150 joules of energy. This is equal to dropping a hammer on someone's head from higher than a 5-story building.
At the FDA hearings, the testimony on the reclassification of electroconvulsive devices cited the literature as whether signed or false, typically about 150 joules of energy in a treatment. With the new Thymatron electroconvulsive device, if you check out at 400 volts maximum of 0.9 amps and 320-some millisecond pulses.
Could you finish up your question, your remarks?
Yeah, I would like somebody to tell me. I'm a teacher as well as a physicist, and I brought a kilogram with me. Teachers like to demonstrate. Now, this is a kilogram. It's 2.2 pounds. Heavier than a hammer used to hit a hand. But I wonder if possibly like Dr. Stein could tell me how high I would have to drop this kilogram from in order to have it hit the ground with 150 joules of energy.
I don't know if that question is in the purview of the panel, but that needs to be reported. I'd like to go on to the next person.
This is only 10 joules of energy. You're talking about dropping it from higher than a 5-story building. That's physics. Supposedly in pre-med backgrounds.
Thank you.
I never got
All right, out with your gun. Out with your gun.
Okay, this won't hurt. It'll be over in just a moment. What's that?
Conductant.
Oh, that will do you. Right, Mr. Jackson.
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well.
Now just bite down on it. That's right. Just bite down. Now bite down on it.
Good. Are you ready?